Hi, Deirdre Verbo here. Oops. Hi, Deirdre Verbo here. Thanks for joining us on Let's Talk Seniors, Memory Care Issues, Alzheimer's, Dementia, and Parkinson's. You may know me from being a senior housing specialist or having written the book Home to Home, the Senior Housing Guide. If you'd like a copy, just give me a shout out. I'm happy to send you one. Tonight we have a special guest on, Neil Anand from ComForCare Home Care. And I've known him for a while. He's an incredible guy. He has a premier home healthcare agency, and he services Fairfield and New Haven County. And what sets Neil apart, ComForCare apart, is that they've researched all things. Oh, there he is. Hi, Neil. I didn't know you were going to come
back for you.
They research all things to do with seniors and go deep and study it and offer classes from everything from sundowning to singing to what we're going to learn about tonight, which is we're going to be discussing the 3 Ds, the difference between dementia, delirium, and depression, and why it's so important to know the difference. So without further ado, since you're already here, hi, Neil. Neil Anand, how are you?
Hi, Deirdre. Very nice to be able to do this again. I know we did another topic in the past, so thank you for having me again.
Yeah, well, What I really love about you and what I think really sets you apart is that you really study and send out a lot of information to people, especially everybody's, home with if they're home with their seniors during COVID. It's good to have all this information disseminated, and you really do a lot of research and help a lot of people.
Thank you. Yes, and so all of these resources are available to the community. Anyone who's attending this or later, if you send either Deirdre or me at the end, you'll see my contact information. We can send this to you as a piece of reference. So let's get started.
Why don't you tell us a little bit about your agency first?
Yeah,
How
sure.
long have you been around? What are you doing? How are you staying safe during COVID?
Mm-hmm. Yep. So I'm Neil Anand, the owner of ComForCare Home Care. The office is based in Fairfield, but we cover Fairfield and New Haven counties. We provide in-home care so that you can continue to live independently at home. And we, everything we do is very personalized. So we're not trying to come in trying to change, your routine or necessarily tell you what to do. We're here to assist so that you can continue to live independently, live your best life possible. So we have assistance with what's called activities of daily living, bathing, grooming, transportation, meal prep, light housekeeping, laundry, really anything that's going to be able to assist so that you can continue to live at home. So we do also have a specialization in dementia care, which is part of what this topic is, and we've had some other presentations around it. All of our caregivers go through a very comprehensive training, which is a dementia-wise program. It's something we've developed in-house for many years, recognized by the Alzheimer's Association. And this is an education that we also do and want to provide at no cost, free to the community, so that family caregivers also know, how to handle challenging behavior, how to, if a family member going through this when we're not there. We do also have versions for professionals, nurses, and social workers where they do get CEUs, which is continuing education units, that they need every year. So, and we also do that, at no cost as part of the community. I guess the rest I will go through in this presentation if we can load it up.
Sure. I think it's very important because what I get a lot of, and I guess you probably do as well, as people are either saying, I'm so close to mom and dad because I'm staying with them that I don't see the decline, or, oh my God, it's been like a year since I've seen them and there's been like such a decline. So either way, it's hard to tell what's depression from isolation, what is happening with them. So let's get some answers to the understanding the 3 Ds: dementia, delirium, and depression. And I'm gonna add us here to the screen.
Okay. So I have this on full screen. Is that that something we can do, or?
It's pretty much on full screen now.
Yeah, no, like on my own thing, I have it on full screen. Okay, this can work too. Let me just see if I can get this.
I see what you mean, yeah. The trials and tribulations of live Facebook. We can see it though.
Okay. Can you see the next slide where I advanced it, or?
No, you didn't click on it. Did you click on it?
So you have to click on it. Okay, got it.
You have to click on like the next one.
I did. Yeah. Okay. So.
Nope, we're still on understanding the 3Ds.
Right. No, I can see that on. What's that? Oh, okay. There's just like a slight delay. Okay. Hold on 1 second. All right. We'll get this going. Okay. There we go. Okay. There's a slight delay. Okay. Okay. So, just a little bit about us. So, like I said, I'm Neil Anand, and we serve Fairfield and New Haven counties. Our agenda today is 3 things, essentially, right? It's to share knowledge of the 3 conditions that impact older adults. And that is, excuse me 1 second. Let me just make sure I get this on full screen. It's to share knowledge of the 3 conditions that impact many older adults. And I know this is not a, it's not a very upbeat topic, but it is very important. And what's good about it is that there are, ways to manage and treat, and being proactive will certainly improve outcomes. So it's to share knowledge of the 3 conditions: delirium, dementia, and depression, and then look at what the similarities are and what the differences are, because you can think it's one thing, could be another. To raise awareness that these can occur in combination, and then also to enable you to understand what the different treatments are that are available. So I know there's a little bit of a delay in the next slide, so I'll just keep talking, and I'm sure you'll see it shortly, and I'll make sure I click on it. So just kind of like an overall how to use this information. This is for educational purposes only, so we're not doing this to be diagnostic or serve as any kind of substitute for medical advice. So, this should be really good education, but definitely, consult with your medical professional, if you recognize any of this, so that they can give a little more specific diagnosis and treatment. The terminology, we're going to go through terminology facts that are related to the 3Ds. Essentially, these are all different than regular forgetfulness. Sometimes people call it a senior moment or being aging. They're all caused by specific problems in the brain, not normal aging. And you can help your clients, your loved ones, recognize this and get the right care at the right time. So let's start with dementia. So dementia is an observable and unfortunately an irreversible decline in many skills, and that could be memory and attention, orientation to time and place, gait and balance, processing information, languaging, reasoning and judgment, regulating emotions. This is something we don't have a cure for right now, but there's definitely light at the end of the tunnel, and definitely been working on it. So dementia, a lot of people think of it, they think about Alzheimer's, right? So dementia is a lot of different conditions, Alzheimer's being about 70% of it. There are different types of dementia, but ultimately, like most people are familiar with Alzheimer's disease. Again, there's no cure, and the early detection of dementia is challenging because the onset is very gradual, right? You start to see mistakes, you start to see subtle symptoms. You might not think a lot of it, and they can go unrecognized. These symptoms can progress along the continuum from forgetfulness, and then at some point, usually requires total assistance with self-care. It can include incontinence, failure to recognize relatives, including your own spouse. And we've seen this with our clients. Delirium, on the other hand, is more acute. Okay, and so that means that it can be reversible, and it is normally a reversible change in someone's behavior. It can be characterized by clouding of consciousness. It can be mental incoherence, difficulty maintaining concentration and attention. And usually the cause of this is some sort of underlying, some sort of underlying physical or mental illness. It could be infection, it could be pain, medication interaction. And then there's other things that can cause this: constipation, dehydration, change of environment, trauma, hypoxia, drug or alcohol withdrawal. And this is something that requires immediate diagnosis.
So can I just interrupt you there? So delirium, it's sometimes we've noticed like people, if we first suspect a UTI, urinary tract infection, when they start just acting differently than they did before. But I didn't know dehydration could do that to you, and constipation even.
So actually, good point. This actually goes to the next. Yes, you're definitely correct about that. So like the next slide, and the next topic.
Like, if somebody's out of sorts, the first thing you should do is check like medical issues.
So here's something that's interesting. So delirium is common in the hospital setting. 11 to 42% of older adults develop delirium while in the hospital.
Wow.
Now this is, I think a lot of it is due to like change of scenery, right? Especially when you're not where you are, you're not home. People want to be at home. So to your point, some of the measures include, some of the measures to prevent it would be to involve family members in care, or professional caregiver, frequent orienting cues, hydration, nutrition, and then to your point, avoiding urinary catheterization and reviewing medication, avoiding any drug interactions that go through it. And then while you're there, because if you think about it, you're in the hospital, you're not, there's probably not a lot going on unless people are visiting you, or you got to provide some activities that stimulate the brain function, reducing the noise, avoiding any sleep interruptions. And then
how do you do that in the hospital? They come in and check on you constantly.
But it's not, they are to make sure that you're okay, but it's, they're very busy, right? It's really just that. It's not that actual companionship or interaction that a family member or a professional caregiver can do, especially when it comes to providing any kind of stimulation towards brain function. So, you're not just sitting there. But that's what ends up happening, which is why a lot of delirium is caused when you are hospitalized. Just looking at some stats now, like I said, it's about 11 to 42% of older adults that get delirium in hospital stays. Let's see, older patients who go to the ER, up to 30%, long-term care home residents, 6 to 14%, surgical patients, 10 to 15%, cardiac surgery, 30%, hip fractures, 50%.
And how long does this usually last, the delirium?
Usually it's, it really depends. It can be just the length of the stay, and maybe a few weeks. It's one of those things that usually it's after surgery or hospital, so you can kind of think about what your recovery looks like, how long it takes to recover. So it can be days to weeks, but it is acute, and it's not meant to be long term. It can be treated, unlike dementia, where unfortunately it's managed, but there's no cure.
And how do you treat delirium? Do you treat delirium by hydrating and seeing if there's something medically wrong and stimulating the brain, like you said, or is there a different way?
Yeah, so we will definitely get to that. Some of it is the social stimulation, like I said, that stimulates your brain function, making sure you don't have any kind of issues like constipation or any kind of additional infection, and then also ensuring adequate hydration and nutrition. Those are probably the three big things. So then when we So now, okay, so the third one is depression, right? This can happen at any age, but essentially it's a change in mental status, right? And this can be feelings of sadness, tearfulness, emptiness, hopelessness. We've all had periods like that, and for some people it's prolonged. It could be angry outbursts, irritability, frustration. Of course, any kind of loss of interest in, activities that you normally like, daily activities, sleep disturbances, lack of energy, like trying to do something simple takes so much effort. Reduced, and then interestingly, it can be reduced appetite, weight loss, but for some people it can be increased cravings for certain things, which cause weight gain. Overall feelings of worthlessness, guilt, past failures, trouble concentrating, in more severe cases, suicidal thoughts, ideations, and then just some like unexplained physical problems that you never had before, like back pain or headaches. So everyone knows that depression can range from mild, temporary episodes of sadness to severe and persistent depression. A lot of things can cause this. Loss of a death is loss of, a loved one, that can cause some traumatic stress, a medical condition, and also medically a thyroid disorder. So major and clinical depression is more severe, as we know. It can affect people at many ages, but it really does tend to skew more towards older adults. And honestly, my opinion is that a lot of it relates to loneliness. I see it, a lot of times with clients, and when we come in, we do all the things we can do to help, but like it also, the companionship aspect goes a very long way. It's something that's very often misdiagnosed, and can unnecessarily result in increased use of health services, longer hospital stays, which again can cause delirium. Not a good, if it's not necessary. Poor treatment compliance, like your post-care plan, and even early death. So I think everyone kind of, knows someone or themselves, who's gone through that. So of course there are antidepressant medications, as well as psychological counseling that can help with that. So there is, in that way, there is some sort of a treatment, and also hopefully a cure for most people. The one thing to know is that out of the 3Ds, depression is the most prevalent neurological disease in older adults. It's about 10% of the population over 65 plus. And then after you're 65, that rate usually doubles. And then when you're 85 plus, they think that as much as 50% of seniors 85 plus suffer from some sort of dementia.
Wow. And this year has been a tough one.
Mm-hmm.
Being isolated. Do you see a big change this year in the people that you visit?
Yeah. Unfortunately, that's probably, at least for this year, has probably gone up. I've seen it. Obviously, there's a lot of confusion, right, with things like, why are we wearing a mask? But then also not being, let's say you're in an assisted living community, not being able to, see your neighbors and go to like the dining hall. And then if you're home, you are better off, I'd say, like in terms of, like as far as the safety concern, but you're not seeing your family as much as you can. And that's where like people like us come in, family caregivers, we can do things like this, get online, get on on the internet and do some, video chat like this with family members, because they were scared to see them until, let's say, for example, they're fully vaccinated or they know they're okay. So like that has caused, it has, and particularly people with dementia, because there's already the confusion, and now there's just an added level of that.
Yeah, especially when they go in and out of lucidity and they're confused as to where's my family? Like, why am I here? What am I doing? Why can't we go out? What is?
Mm-hmm.
Really not fun.
Yeah. And the good news is it's getting better, right? So like I think almost all my clients are seniors are vaccinated. So like, they're starting to be able to do more things and go out. So we are getting back to it.
Somebody notices this in their parent. What should they be doing if they notice dementia or delirium or depression? And now that they know the difference, what should they be doing?
Well, You have to look at some trends, right? You have to look at like, is this just like general for forgetfulness, or are you noticing this over like, let's say, weeks at a time? And that's when you want to talk to your primary care doctor, because it could be something else. And normally, most primary care doctors, ultimately, if they feel there's an issue, will refer you to neurologists, but they have mini mental exams. There's the MOC, the Montreal Cognitive. There's things they can do kind of like as a pre-screening, when you go for your next checkup, but you don't have to wait till that either if you feel like there's an issue. But let's say, you have your annual coming up. Start talking about that and get those kind of ask about getting those kind of tests done, so that at least that if there is something, let's at least talk to the next step would be to talk to a neurologist. I would say anybody over 65, 70 years old, should start, just make that part of their annual physical, and that is something that is included through your insurance. I believe when you reach Medicare age, so you should not leave it out. You should include it as part of your checkup.
So if you go to a neurologist, I mean, I hear a lot of people say, well, it's old age, like everybody gets like that or whatever. But through a neurologist, they can pinpoint the different kinds of Alzheimer or dementia you may have, correct? And then there's different protocol.
Yep. So they can do that, but then also realize, and understand like what stage do we think we're in, right? So not everything has to be managed from medical way. You don't have to start taking Aricept and Namenda, which we'll get into. There's like most common treatments for it, medicines. Like there are things you can do, before we get to that point. So yes, you kind of want to see where you're at, and then they can go from there. Okay, so the next is just signs and symptoms, but then also we just want to look at, like, this is very confusing, right? Because a lot of these these 3 Ds look very similar. So what are the similarities and differences between the 3 of them? The similarities among them, among all of them, are mental confusion, behavioral changes like anxiety and agitation. Some of that can be short term, some can be long term. Difficulty doing daily activities. I think we've all seen that. Weight loss, weight gain, right? Just what's abnormal for your weight. Decline in social participation. I don't want to do anything anymore. Again, that's a lot of it's depression, but it can be all of these. Memory loss, usually short term. Communication breakdown, sleep disturbances, and then just in general, causing a lot of stress and distress for family members and caretakers. Just not understanding why this is happening. So those are a lot of similarities.
When you say sleep disturbances, Neil, you mean people get up in the middle of the night and can't get back to sleep?
Yeah, not just in the middle of the night, but sundowning, right, is very common with dementia, where like, around 2, 3 p.m., some people say, oh, like, I don't have dementia, but like imagine like 2, 3 p.m. Like I need that Red Bull, right? Like, or whatever. Some people feel that way. They have that slump. The difference is around people with dementia, for example, and the other 2, they feel that, but they also get very emotional and agitated. That affects their sleep later during the day, or they're sleeping too much during the day and then can't sleep at night. So as much as you can do to keep a routine, people who are on that is very helpful. So yeah, that affects it as well. Trouble sleeping, I guess, is the end result.
So it's good to keep a routine and not sleep so much in the daytime, but your nighttime is all thrown off.
Yeah, you should sleep when your routine is to sleep. Like, it shouldn't be erratic. It should be as consistent as possible. I know that's difficult, but yeah, definitely not during the day if possible. Naps are okay, but what ends up happening is it creates an issue later in the day.
Okay.
Now, there are a lot of differences, and there's this chart I'm looking at right now, and we'll, I'm happy to share this out. What I'll highlight is the differences within the 3 Ds is, let's just start with onset, when this all starts, right? So with dementia, it's insidious and it's a gradual onset, right? Like, it's people with dementia, once they get it, unfortunately, they live anywhere from 3 to 7 years. So, but it's gradual and it progresses. With delirium, it's very sudden, it's acute, and it's depending on the cause, and it's very bad at night, particularly. And then with depression, it's usually related to specific events, also acute, can be managed. As far as speaking, with dementia, you can become very disoriented. You're rambling. You can't pronounce nouns correctly. With delirium, it's more of like a slurred speech, rambling. You start to be a little incoherent. And then with depression, it's also, again, slow and sluggish and processing responsive verbal commands. As far as cures, let's just call it reversibility. Dementia, irreversible right now, right? We're working on it. No cure, it's progressive. Delirium, usually it's reversible, right? Because it's acute, it's short term. And depression is what we would say potentially reversible. Some people might have it for life, but usually with the right techniques, you can get over that. And I think people, no matter what age, have gone through periods like that, and then they get better. So those are kind of like the overall differences between the three. But distinguishing between the three is difficult because they're often the easy way out, or maybe just what the thing is to diagnose one versus the other. Usually depression, and then we just talk about treatments, right? So in summary, with dementia, the treatment, the best is early detection, right? Because it's long-standing, it's progressive. So you want early detection to empower clients, family members to be decision makers in their own care. You want education and support to improve their quality of life throughout the progression, knowing that it is going to progress, unfortunately. You want over time medicine. These are brain boosting medications, they call it, right? Aricept and Namenda are the two common ones right now. That's what most neurologists will prescribe. But there are also non-pharmacological approaches for managing these symptoms. Having home care, having a family member engaging in meaningful activities, puzzles, old memories, things that they enjoy. It stimulates the brain. Delirium is all about early detection of underlying causes. What's the underlying cause? Why is this happening? Like I said, it could be hospital stay. That's very common. And then education regarding polypharmacy to reduce the risk. Depression, again, early detection. Depression can be treated, it doesn't always have to be, there's antidepressants, but psychological counseling obviously goes a very long way. Depression can be very situational. It doesn't have to be forever, just like delirium. So you want to, again, understand the underlying cause. So all three of these are serious conditions among older adults. The overlapping symptoms can go undetected and untreated, but while they look similar, when you find the effective treatment approach to each condition, it can be managed, and really for the other two, it can be cured.
So Neil, can I interrupt you? You said dementia usually lasts 3 to 7 years.
In general, that's usually from 3 to 7 years is usually when someone passes away from it. Yeah.
So is it like it progresses that much that it's like a death sentence, or is it just?
Yeah. As of we're working, right. Everyone's working on a cure, but yeah, as of now, there's no cure. So that's like the average. I see it my own clients. I just had someone pass away. He was fine about I don't know, let's say about a year ago. Well, he wasn't fine, but he was a lot of memory issues, but he was still able to walk. He was, he had his wife. We take care of his wife too. He was able to. She had mobility issues. He was able to push her around the wheelchair in the community they lived in. They go to, they would still go eat lunch together, but he would forget things short term. It would make her very frustrated. That's why, we were there to help. And honestly, unfortunately, nicest guy, but I'd say within a year and a half, he was bedridden. He couldn't move, incontinent, so unfortunately, yes, we're not there yet. I hope we will be one day. I would love, even though we help people with this, I'd be more than happy to have a cure for this, because it is progressive at the moment. We're working, we made some strides, but we can slow the progression, but there's still no cure.
And how are ways of slowing it? What are some of the ways?
So the medications I just talked about, right? That's normally like what a neurologist would recommend. Early detection is actually the best way of slowing it because there's a lot of things you can do. There's medication you can start doing earlier. There's something called a PET scan, PET scan that you get done early, and there's two proteins that that factor into this amyloid and tau in the brain, and they when that plaque builds up, that's what eventually causes it. So what scientists are trying to do is figure out how do we get rid of that. It's almost like coronavirus. We develop RNA vaccines. We have a spike. We want to target the spike protein so that it can't replicate itself. It's a similar concept, and I actually have a lot of confidence now that we put the world's resources behind these two vaccines, Pfizer and Moderna. That same technology, I think, is going to cure cancers. I think it's going to work towards this. It's going to take some time, but we're literally altering genetic sequences, which is what dementia is. It is genetic. So
that would be fantastic.
Yeah.
Unbelievable.
What's that?
That would be unbelievable. That'd be fantastic.
Yeah, I mean, yeah. So what we're seeing with what we just, people say, oh, like how did the, how did we develop this vaccine so quickly? It only takes a longer period of time, and it does. But this is a technology we've been working on, like I think for 20 years. And then when you put the world's money and resources behind it, things do get sped up. And the same kind of technology can target cancers. It can, and it should be able to do this. And so I do have hope, but right now, unfortunately, it's more just managing it. But hopefully one day there'll be an actual cure.
Wow, that is. It's funny. I have my girlfriend. I was actually at lunch with her today, but her dad was he was in his early 80s, and he was working as a CPA. He owned his own company, and then went into the hospital, and seemed to go downhill in a heartbeat. And it was total. Now I think it was total delirium, and he just looked like he just lost it completely. But it went on for weeks and then months, and my girlfriend had to close down his CPA business and put him in a home because he just wasn't recovering. And then, or he was just getting worse and worse. And he said, I want to go home. I want out. I want to go home. And she's like, if you could get yourself home, you're welcome to go home. And somehow he called and figured it out. He was in Vermont, got himself back to New York and got a caregiver and set all up himself. And it was the medicine he was on, just making him seem like he had immediate dementia and couldn't do anything. And it was just crazy because it was for months. And he was now, from what you're saying, he was in this delirium state for so long that, she closed down his whole business. She was going to sell his house. And he went back home, and then he did need care for a number of years before he passed recently. But it was insane. It was an amazing, miraculous recovery, but I could tell now it was not dementia. He was just delirium. He was in a delirium stage. It must have been from the medicine he was taking, and it really caused a lot of harm.
Yeah, there's so many. I don't know, just people got to be careful of medicines because there's a lot of side effects to it, and that's not always a cure. There are if you're the daughter or a loved one, the wife or whatever of somebody who's going through this, how would you know that it was delirium, or how would you who do you turn to figure that out? If right,
it's a tough one.
Yeah. So and honestly, doctors, you got to spend some time with your doctor. One visit might not determine that. You have to kind of see what's going on over time. So I know we're getting close to time as well. So in conclusion, is there any questions? So our agency, Providing Home Care, we're here to help. We with home care assistance, specialization in all of this. Personally developed care plans and coordination of care, along with all the community resources we have. So you can always, my info is there. You can always reach out. Everything's personalized. There's no long-term commitment. There's no minimum in terms of, it's kind of what you need, and we'll tailor a plan around that. And as things change, we can always adjust. But yeah, small things can go a long way towards all of these.
So Neil, if your people are trained in all this, when you're in somebody's home, are you bringing up to the family, like, I think that your mom or dad might have dementia or depression or delirium? Are they noticing that and reporting it back to the families?
Yeah, it's kind of half and half. Like sometimes they already know that because they've had official diagnosis, and now it's time to get some extra help. The doctor said it, and so it. And then sometimes they don't. It's like she's just, something's wrong. She's lonely. She's not. She doesn't like to do what she likes to do anymore. She doesn't want to go to the senior center. And then that's where we come in. We we spend some time and kind of see what's going on. We do a whole fall risk assessment too, which is separate from this, but dementia can affect gait and balance too. So you start to see those kind of things too. Usually it starts with memory, but they'll notice. They don't live close by. I called her. She can't even remember what she had for lunch. And then once we get to spend some time face to face, we'll have a much more accurate picture of what's going on. And like I said, sometimes they already know because they got official diagnosis. Sometimes it takes a little bit of time to spend time with them and then say, hey, let's go see the doctor. You haven't been there in a year. And then, from there we can determine, a more set care plan.
Sounds good. You must be super, super busy these days.
It's we are, but it's been great. We've been happy to keep people at home. We've had 0 cases with COVID since this started, and I think a lot of it is what we're doing, but also because they have the people we work with can stay at home. They're not as exposed. So now that the vaccinations are happening, we're a lot more confident that people, we're going to be okay. People are going to be able to get out there, and because that's the other thing too. The isolation and loneliness can cause a lot of these kind of things. I
mean, it's taken a toll on everybody, and the seniors are the worst hit, really, because we're really trying to protect them, and they're really lonely to begin with if they've lost their family or their spouse, and so it's just wow. This has been taking a huge toll on so many people, and seniors have been hit the hardest for sure, and we have to protect them.
Yeah.
But Neil, thank you so much for coming on. ComForCare Home Care, 203-612-8966. Feel free to reach out to Neil. Services Fairfield and New Haven, and he has a bunch of very well-trained CNAs. You also have nurses and home health care aides, and right?
Yep, correct.
Yeah. Okay, super. So if anybody is in need, and if you find your loved one is home alone and they could definitely use some extra care and love and support, give Neil a call. Thank you so much, Neil, for educating us and keeping us all informed of all the different topics on seniors. I really do appreciate it.
Yes, thanks, Deirdre. And yes, until next time, we'll do it again. Thank you.
You're full of good information. You're full of very good information. Thanks so much for all your info.
Thank you so much.
That was Neil Anand, ComForCare Home Care, 203-612-8966. He really knows his stuff, and his dad's a doctor. He's been in the medical field and profession, and so even though it's kind of non-medical what he does, he really understands seniors and dementia and delirium and depression, and it is really a big concern with our seniors. So if you notice that your parent or loved one is experiencing any of these, reach out and see if you can get them some help. Well, thank you so much for joining us on Let's Talk Seniors, Dementia, Alzheimer's, and Parkinson's. I look forward to seeing everybody the next time. And if you're interested in coming to see Just Like Home's Dogwood Home, where we have a home, not a facility, a home for 6 seniors that have assisted living needs and dementia, we are happy to give you a tour and show you around. It's right here in Shelton. So thank you so much, everybody, and until next time.
Hi, Deirdre here again. Thank you for joining me on Let's Talk Seniors Memory Care Issues. Is this an issue hitting home? Do you have a parent or loved one with memory care issues who feels not safe at home anymore? Are isolation, falls, and safety issues becoming a big concern? Welcome to Dogwood Senior Home, premier boutique residential senior living specializing in memory care. It's country living at its best in the Huntington section of Shelton, Connecticut. We're truly a home with only 6 senior residents living as one family unit. Senior residential homes are a concept sweeping the nation with 47,000 across the U.S. We're pleased to open Dogwood Senior Home as it will be only number 6 for Connecticut. Brand new, sparkling clean, opening mid-June. And safe, safe, safe. We are COVID-free. Residential care homes boast a very low COVID infection rate across the nation. This is due to the intimacy of size and speed in which the caretakers can shift to accommodate immediate needs. They are much safer than the large homes and facilities, as you can imagine. It has been documented that residents have less falls and a better quality of life in a residential home environment. Our home is more affordable than the big box facility. You pay one all-inclusive price, and that price is guaranteed for the life of the resident. With an incredible 1-to-3 caregiver ratio, which you won't find anywhere else. Our friendly, loving caregivers are dedicated and trained in Alzheimer's, dementia, and Parkinson's issues. We're only taking 6 residents, so the home will fill up fast. Call me at 203-689-7562 for a talk and tour. I would love to meet you and your loved one. See you soon. Bye.